Okay, we will continue with chapter 36, which is musculoskeletal injuries. And in musculoskeletal injuries, of course, we're going to talk about mostly fractures, dislocations, sprains, strains, and so on and so forth. Again, not much has changed in the musculoskeletal injuries world than what you've already learned at the EMT level. However, we will review quite a bit of material and note that, of the times that we may want to break out our nitrous oxide, this may be the biggest time that we see this is when we're talking many of these, because they are particularly painful. I'll apologize ahead of time. Over the weekend I've been suffering a cold before recording this, so it's I think it's kind of taken a toll on my voice a little bit, but nonetheless, we will persevere. And just as with all the other chapters, if you have not read and studied the chapter, please do so at your earliest convenience. Simply watching or listening to the lecture is no replacement to self-studies. We continue with the same theme of the advanced EMT applies fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings of an acutely injured patient. There's a couple of multimedia videos that are found in the non-narrated PowerPoint. You have several objectives in this chapter that you'll find on pages 817 and 818. So an introduction. Generally speaking, isolated musculoskeletal injuries are not life-threatening. The majority of those that we see are, of course, those that are things like hands, fingers, toes, forearms, even lower legs, or even upper arms, the humeral fractures. Many of those are not particularly life-threatening. Some of them occasionally have the potential. So let's say if we get a rib fractures, we know if we get a displaced rib fracture, we certainly could puncture a lung and end up with a pneumothorax, which would make it life-threatening. Also, people with rib fractures tend to not want to breathe very deeply, and when they don't breathe very deeply, they're more common to see them catching a pneumonia of some sort or a bronchitis, which then has the potential for it to be lethal, although in most cases it is not. So most cases, though, we are dealing with a very isolated, simple injury that's just going to need some minor medical attention. Severe internal or external hemorrhages can occur as a result in a life-threatening condition. So the big bones that we have, femurs, pelvises, humerus to an extent, but mainly the femur and humeruses that have such a significant, femur and pelvis that have such a significant blood supply and so many large vessels that run along them are the ones that we're particularly concerned with as potentially causing a life-threatening internal hemorrhage. Of course, anytime you have an open fracture, it's hard to say what's going to end up potentially being damaged in the process. So if you bust a femur in half, you could very easily, one of those sharp bone ends of the femur slice through the femoral artery, and that doesn't take long at all to pump out a significant amount of blood. Musculoskeletal injuries are part of multi-system trauma. It's probably one of the more common types of trauma that we think about. However, if you also stop to consider the major traumas that we deal with, when we talk about head injuries or chest injuries, we almost always will also have musculoskeletal fractures to go along with them. So multi-system trauma, if we're talking about things such as a pneumothorax or a hemothorax or a pulmonary contusion or a cardiac contusion, anything like those things, simply for the fact that it generally had to go through a bone. The energy had to be transferred through a bone to get to the soft tissue or the organs on the inside. Do not be distracted from your priorities of patient assessment and care by a dramatic appearing musculoskeletal injury. So if you have something that's in a very odd shape, very odd position, that can draw your attention away. But remember, a broken forearm in most cases is not going to kill this person. However, that pneumothorax that they have or the hemorrhage in their abdomen that they have could. So make sure you pay attention to your primary assessment stuff. We go back and take care of that other stuff later. We continue to strive to look for problems with the airway, breathing, and circulation, and that's what we're really driving to prevent the patient from having any. That's the life-threatening stuff right there. We need to recognize the life-threatening musculoskeletal injuries and their mechanisms. So if we have things that say head, pelvis, chest, or upper legs, we recognize that there's the potential there, and we watch for the additional signs and symptoms of hypoperfusion that go along with them. So if we take a few moments to recap anatomy and physiology a little bit. Of course, we have the skeletal system, which we think of probably most commonly. We have 206 bones in the average adult human body and over 700 muscles. These work together to provide shape and locomotion for our bodies. There's red blood cell production occurring in the bones. There's heat being produced by the muscles. It protects our internal organs either together or alone because like over the abdomen, we have muscles. We tend to try to build our muscles up over our abs to protect those internal organs because there is no skeletal protection there. We do around the thoracic cavity, but not around the abdominal cavity. We have accessory items that go along with them, such as ligaments. Remember, ligaments tie like things together, so a bone to a bone. Bones are alike, they tie those together. And we have tendons. Tendons connect muscles to bones. So the biggest and probably most famous example is your Achilles tendon, which runs off from the back of your calf down to your heel bone. Skeletal muscles are also referred to as voluntary muscle, and those skeletal muscles have striations on them, and they are usually work in tandem, although they work generally opposite of each other. Say, for example, the bicep and the tricep. The bicep helps you flex your arm, but the tricep has to stretch. So while the bicep is flexing, the tricep is extending. And then vice versa. When you want to extend your arm, you're actually flexing your tricep and extending your bicep. Ligaments, again, they connect bone to bone, tendons, muscles to bones. And then we have cartilage. Cartilage is usually in a transition from one bone to another. So depends on the joint we're talking about. Maybe something like your ribs, where you really have a non-movable joint. You have a little bit of a flexibility in that costal cartilage, which connects the ribs into the sternum. But for the most part, you don't have a movable joint there. Whereas if we talk something like a knee, of course we have lots of cartilage down there, as well as other things like bursa and all kinds of other little ligaments and smaller muscles and whatnot that tie things together down there. They can provide some shock absorption. They can allow the bones to move against one each without friction, kind of like putting a little slick pad on the end to allow for them to slide nicely on each other. And then provides us some structure without the severe rigidity that we get with bones. So the bones of the upper extremity, just in brief review here, your collarbone on the left side left side of the screen here, your left, you see the anterior, so the front, and so with clavicle is your collarbone, humerus is your upper arm, radius and ulna being those in your forearm. Radius is on the thumb side, ulna on the pinky side. The bones collectively of the wrist are the carpals. Of the inner fingers, where the fingers are not separate, are the metacarpals, and then where the fingers actually are in separate digits are the phalanges. If we look at it from the posterior side, we have the scapula on the back side, which is our shoulder blade. So of the humerus, the olecranon process is what most people call their funny bone, but the olecranon process ties the ulna in with the backside of the humerus. It fits in a little groove back there. And we still, of course, have the radius, ulna, carpals, metacarpals, and phalanx. Lower extremities, anteriorly, we're looking at it from the pelvis. We have the iliac crest, which is your high hip bone. The ilium, which is really the kind of butterfly wings of this bone here. The sacrum in the back, remember that's actually part of your vertebrae. It's part of your spine. It's all fused. You have 5 sacral vertebrae fused together there. We have the ischium, which is down under the pelvic bowl there, kind of 2 eye-like things looking under there. We have the symphysis pubis that ties the pelvis together in the front. And then those all get together to make up the pelvis. On the outside of the pelvis, where the legs attach in, we have the acetabulum, which is a socket or a dish, basically. It's rounded out, almost looks like somebody took an ice cream scoop and scooped out the bone there. And within the acetabulum goes the head of the femur. That head of the femur sits in that socket there and gives some stability so we can walk. And then you have the various parts of the femur between the neck of the femur, which is between the head or the ball, and then the actual bone, the long bone part. You have the greater and lesser trochanters. Goes down through the shaft of the femur, down to the condyles of the femur. You have the patella that covers the joint between the upper and the lower leg. The patella is actually referred to as a sesamoid bone. Sesamoid bone grows in the middle of, really in the middle of a tendon. So it grows there, and or actually a ligament, but grows in the middle of that patellar ligament. So going down from there, we have the tibia, which is your shin bone, fibula, which is on the outside. The only place you can find your fibula touching yourself is if you go all the way down to your outer ankle. We have the tarsals, the metatarsals, and the phalanges. Tarsals are those of the ankle. Metatarsals are the bones of the toes that are still all inside the foot, and then the phalanges are the visible separate toes. The calcaneus is your heel bone. We again have 206 bones that comprise the average adult skeletal system. We have the axial and the appendicular skeletons. You remember that the axial skeleton is really all those bones of the core. So if you can look in your textbook on page 820, you will see in the full skeleton picture there, figure 36.1, the bones that are in yellow are the axial skeleton, and the bones that are in the brownish tan are the appendicular skeleton. So things that are of the core are central. So they are categorized by long, short, flat, and sesamoid, the various types of bones that a person has that have various functions. So we have things such as, most of what we think of when we think of bones, even from, say, a cartoon sense when we were a kid is we think of long bones. They have a long shaft to them, and then they have a head on either end of them. But the long bones are femur, humerus, radius ulna, tibia, fibula. That's where a majority of the blood products are produced. We have the short bones, including those of the metacarpals, metatarsals, and the phalanges. So these are similar, just shorter, significantly shorter, smaller bones. Flat bones, so things like the sternum, the scapula, the ribs. There's also another category that's called irregular bones. The irregular bones are actually where you get things like vertebrae that fit into that. And then we have the sesamoid. So sesamoid are generally in the shape of a sesame seed, and really the ones that we talk about the most are those of the patella and the pisiform in the wrist, which is one of the carpals. So our bones, they are obviously a living metabolically active tissue. They have significant blood and nerve supplies to them. They will usually have significant blood flow through the middle of the bones, particularly in the long bones, because remember that's where the blood's created. And we'll often have nerves that will surround the bones as well. Over our childhood and our adolescence, we generally are tasked with trying to store calcium. So calcifying our bones, making them strong, because it's more or less when you're born you kind of have a mesh network, to think of it in an analogy, I guess, a mesh network of kind of a bony structure, but it is the responsibility of your diet as you grow to continue to sock away the calciums and the phosphates and whatnot into that little lattice of bone to strengthen them. And I talked about the bone marrow cavity creating blood. Joints are what we have at the point in which a couple of bones meet that may or may not allow for motion. In most cases, when we think about it, they do. And the types of movement that they may allow is flexion and extension. So basically, if you flex your muscle, flex your arm like you're showing the strongman, flexion, where you're actually flexing one muscle, but you're extending another. We can have adduction and abduction. Adduction is when we pull our arm down to us. If we put our arm out to our side and you lower it down up against your side of your torso and your leg, you have adducted it. Or if you pull it back up outward, so it's out in basically a T shape from you, you have abducted it. Then we can have circumduction and we can have rotation. So it's various circular movements of the different bones and structures. And then we have some complex structures of the bones, cartilage, and ligaments. So sometimes when we're talking about things like the knee is a very complicated little device because of all the different cartilaginous layers. We've got meniscuses that lay in there. We have bursa. We have all the different tendons, cruciate ligaments, and so on and so forth. So it's a very complicated little network in there. Some are much less complicated. So if we were to talk about something like the joints in our skull, which are often referred to as sutures, but that's where two bones basically came and fused together. So here's a think about for us. You and your partner arrive on the scene of a bar fight. The scene has been cleared by law enforcement. There are two patients who were involved in what was initially a fist fight, and then a knife was used at the end of the fight. So what injury should you suspect? Well, if it started out as a fist fight, we most likely are going to believe that there was mostly blunt trauma to begin with. So it's tough to say exactly, where we might suspect things. Don't believe that just because it was blunt trauma that it can't be severe, because it certainly may be. Remember, they don't always play nice, so we're not always talking just fists. I mean, it may have ended up with kicks. It may have ended up with people's heads getting slammed to the ground, so on and so forth. And then once we involve a knife, now we have penetrating trauma, and we need to know a little bit more about that knife and the various areas that the person was stabbed in. So isolated injuries of bones, joints, muscles from a relatively minor mechanism are pretty simple for us to treat and assess. We generally will use a focused approach to them. I mean, I think we can use a good example of, it won't be too terribly long and we'll be back in baseball season. If we would happen to respond to one of the ball fields in our local communities for somebody who maybe slid into base, slid feet first into base, and now has a dislocated ankle. Well, we've all probably seen people slide into base and know that there's not usually a significant amount of inertia there. I mean, it's just the basic one person running and hitting an object that's not terribly movable. So we know that the mechanism and the kinematics are fairly limited in this situation. So we would generally focus just on the ankle then. So obviously it can cause some severe pain. Anybody I think that's had a fractured bone would attest to that. That pain is pretty ugly, at least for a few days. We can also use a long backboard as a single means of providing immobilization for all musculoskeletal injuries. I like to refer to the long backboard as the whole body splint, because in the cases of major trauma, when somebody has maybe some arm or leg fractures and needs to be packaged, instead of us splinting each one individually, provided that there are things such as other extenuating circumstances that are taking our attention away from singular fractures, so a head injury, an abdominal injury, something along those lines, we're going to say, okay, well, we're just going to splint those all by tying this person to a backboard, and as time allows, as hands allow, we may go back and do something to up the ante on those a little. So with our focused assessment to musculoskeletal injuries, we're going to, of course, use our DCAT, BTLS mnemonic. Expose the injured area. You cannot assess it if you don't expose it. If they're complaining of it, you better expose it and look at it. You can cover it back up. You can use your various techniques of examination and palpation. And so what are some of our signs and symptoms of musculoskeletal injury? And we can find those all on page 822 in your text. Pain, deformity, or abnormal position, swelling, loss of function, discoloration, bleeding, crepitus. Remember, that's bones grating. Okay, exposed bone end, that's almost a guarantee. Bruising, hematoma, abrasions, lacerations, decreased circulation, decreased motor function, and decreased sensation for that matter, could all go into potential lead us down that road of believing that we have a musculoskeletal injury. Occasionally, we also have things that become impinged, or we have a neurovascular impairment. So we're looking for things such as CSM. So all that time that we talk CSM or PMS, or I don't care which mnemonic you use, as long as you understand, you need to check sensation, you need to check circulation, you need to check motor function. So I've heard all kinds of different ones here. My preference is CSM, circulation, sensation, motor function, but I certainly can't blame you if you want to use another one. So assessing circulation, usually we do that by checking distal pulses, so radial pulses, maybe pedal pulses. We could check by doing capillary refills in some cases. We're going to check tactile sensation by touching, asking them if they can feel you touching them. probably the best way to do this is not to allow the patient to see what you're actually doing, and ask them to tell you, which hand am I touching right now? And I do 3. I'll touch one hand, I'll touch nothing, and then I'll touch another hand. And that way I get if they're trying to just guess. And then to check motor function, that's usually when we have them squeeze our fingers. We test their grip strength. We have them push down on our hands with their feet. We have them pull their toes up towards their nose. We do those 2 things to help sense the equality of the extremities and their CSM. These aren't the only ways to do this, but generally they're the kind of the industry standard of care. So if we have an impaired distal neurovascular function due to a trauma, transport without delay. We have a limb-threatening situation going on. This is not very common. In most cases, people don't end up with neurovascular compromise, but it does happen. I remember a number of years ago, I was doing a standby at a rodeo and had a cowboy bucked off a bull and landed on his shoulder and dislocated his shoulder, and just so happened to impinge the neurovascular bundle right into the shoulder. So as that kind of shoulder pulled out of socket, some of the nerve and blood vessels got kind of caught up underneath it. Slammed back. It didn't get back into the to the socket where it should be, and it started pinching off or clamping down on that neurovascular bundle. And he lost pulses, he lost color, he lost sensation, and had a pretty horrific amount of pain. So obtain a baseline before splinting. So before we move anybody, we check CSM. And then after we've moved them and or splinted them, immobilized them, then we also will recheck. We can also have additional swelling that can cause impairment. So we may end up with something, say, like, well, there's a couple things. We could have a compartment syndrome that happens. So as time goes on, more and more swelling in the muscle then starts putting more and more pressure on the neurovascular bundle, and that leads to some impairment. We may splint something or immobilize something, thinking we're doing the right thing, only to find out that we applied our splint too tightly, and with the additional swelling that has occurred from the time we splinted it to the time they get to their receiving facility, that extra swelling has now started to compromise the neurovascular function. We can also see things such as a hemorrhage from a major artery. So this one they specifically mentioned the popliteal artery, which is on the back side of your knee. So it's behind your knee. And it can become rapidly fatal. So if we have a lot of bleeding in that really in that upper thigh area, we certainly could see some super negative side effects. So why immobilize? Well, we're going to immobilize to decrease further injury and pain. The more that things move around, and I believe anybody who's had a fracture before would attest to this, the more we have our bone ends moving around and flopping around, the more they're going to hurt. So by decreasing that motion, we decrease the pain. We also decrease the chance that things are getting shredded in there. Think about having nice sharp bone ends just kind of rattling around inside there. With those sharp bone ends, they can certainly cut through other tissues. We'll elevate injured extremities when we can. Sometimes we can't, just simply because of the nature and their location. But if we can immobilize it and we can elevate it, we can also apply cold packs to it. Cold packs will help to reduce the swelling, which in turn helps reduce the pain. So elevating it takes away a little bit of the lymphatic pressure, so hopefully that pulls a little of the swelling away, and it helps drain it so we don't have that buildup of constant pressure. Splinting is using an external device to stabilize an injured extremity, and it prevents it from moving. So essentially, casting is also splinting. We have fixators as well. We don't do fixators in EMS, but when you see the people who broke an arm and have all this kind of funky hardware on the outside of the arm, it looks like an erector set with pins and rods and screws and whatnots on it. Those are called external fixators, and what they're doing with those is basically they have set up the framework for that bone to heal, but it's going to be a fairly lengthy and complicated process. And in many cases, they may also have to adjust those from time to time. As the new bone growth comes in, they'll adjust those fixators to constantly be encouraging new bone growth. So we have lots of different cool splints that we use these days. You know, even 25 years ago, we were pretty limited. We had really, we had rigid splints. We had traction splint, and that was only one type of traction splint, the bipolar traction splint, and then improvised splints. We didn't have a lot of other cool commercial products. So, but sometimes the best splints are the ones that we improvise. All right, so some of our general principles and rules for splinting. Number one, treat the life threat first. Yes, it sucks that that forearm is broken and it hurts, but you know what? That broken, hurting forearm is not going to kill them nearly as quickly as that punctured lung is. Check the CSM before and after splinting. Pad the splints, pad the voids. If we would take just a simple piece of flat wood with nothing padding it, there is no possible way we can fully and completely immobilize something like a forearm with just a plain flat piece of wood. If you take your arm and lay it on a table, say we'll lay it flat on the table so our palm surface is down on the table. There's space underneath your wrist that does not touch in most cases. So that's why we pad. We pad those voids to help keep there from being wiggle room. We don't want there to be a lot of wiggle room. We don't want the splint on so tight that it cuts off circulation, but we want it to pad all those voids so we don't have wiggle room, literally wiggle room, so the arm is not wiggling around causing vibration and extra pain. We immobilize injuries to bones to include the joint proximal and distal to the injury, and we immobilize injuries to joints to include the bone proximal and the bone distal to the injury. So that's referred to as the above and below rule. So if you're immobilizing a bone, you also immobilize the joint above it and below it. If you're immobilizing a joint, you will immobilize the bone above it and below it, because those are the areas in which the most movement is going to occur that can potentially cause further injury. Rigid splints. Rigid splints come in a large variety. We have things like wood, plastic, cardboard, metal. Well, some of them require padding, some of them don't. Depends on what your department has opted to get. There are a lot of commercial rigid splints on the market these days. There's some that are wrapped in either like a orange or a yellow plastic, and that orange and yellow plastic is covering a piece of wood with some foam rubber that's glued to the wood, so it does already have a little padding on one side. Most of the cardboard splints, the commercial cardboard splints, also have some kind of foam inner lining that helps kind of pad some of those voids, but we've got other things that will help pad the voids, whether we're talking bandages or dressings, ABDs and 4x4s, metal splints. Some of them, I have not seen many metal splints in quite some time. They typically are secured in place with either roller gauze, Some of them may have some built-in straps, Velcro and whatnot. You got to be very cautious not to secure too tightly. Moldable splints. The moldable splints are generally fairly pliable, so they can be moved to fit an extremity. And I think probably one of the most common types of moldable splints we talk about these days are by the brand name Sam Splint, but there's plenty of offshoot generics of those. But the Sam Splint is basically a metal, a thin aluminum sheet of aluminum covered by some foam that you can bend into all kinds of different shapes. I'm sure everybody's pretty familiar with that. Prior to those, we had something called ladder splints, which were very similar. They were a long little lattice that was very flexible, but we had to cover those with gauze anytime before we used them. We have air splints, pressure splints, or pneumatic splints. So they're often zippered like this one that they show here in the picture. Usually are blown up by mouth. They're less than favored anymore. They are cheap, which makes that which is nice. And most of them these days actually will have cutouts at the toe and the finger, so we can assess CSM, whereas this one does not. But we blow it up, and we have this like wall of pressure, this wall of air around that kind of gives it not only some rigidity, but also a little padding, a little cushion to cushion the blow from any bumps and whatnot in the road. The biggest problem to air splints is, number one, they leak in most cases because they'll get punctured, and next thing you know, it's losing air. Two, in the wintertime, we blew up this splint in the house where it was 72 degrees. We blew it up with 98.6 degree air out of our mouth, and now we take them out and it's 2 degrees outside. And what happens with balloons when you take them outside? They shrink. Well, same thing happens here. So they lose that ability to give support during the time that they're exposed to the cold outside elements. Vacuum splints. Vacuum splints are probably one of the most favored splints of the day. They are a fantastic splint. Biggest problem with them is they are expensive, and if you get one gets cut or punctured, you could be out a fairly good amount of money. But vacuum splints are essentially a beanbag in which you flatten out the beanbag, you wrap it around whatever it is that you need to splint, suck all the extra air out, and those beans kind of get packed in tight together and give us a nice rigid, firm shape to immobilize the various extremities. They tend to be much less prone to changes in temperature than do air splints. We have a good old-fashioned sling and swath, which are pretty easy to do. Sometimes we'll use it with a splint, sometimes we will not. In this case, looks like they're immobilizing a forearm. So they've immobilized a forearm with the rigid splint. They have a piece of or a roll of gauze in the guy's hand to put it in a position of function, and then they have slinged it, which is the device that goes up around the neck, and then swathed it to him, which is the part that goes around, circles his chest and his arm to hold it tight up against his body so it's not bouncing. Slings and swaths can be used for things like upper arms, shoulders, but also to help reduce the amount of movement that we would have, say, in a forearm fracture. Might also be helpful in a clavicle injury. Kind of depends. You're going to put extra pressure on the clavicle by putting a sling on them. Sling and swath gets supported, supports the arm by suspending it from the shoulder, and the swath is a bandage or strap that wraps around the torso. example of a triangular bandage that's been unfolded. If we leave it rolled up but not pulled out, is referred to as a cravat. So when we have it kind of rolled into a 3 or 4 inch wide band, it's a cravat, whereas the sling is for triangular bandages when we unroll it completely. So to appropriately apply a sling in a swath, I will tell you that there are differing schools of thought on how you should appropriately apply the sling. This one shows one option. I actually prefer to go the other way with it, but where they're going to put the inside layer of the sling over the opposite shoulder. I think there's a lot of places that recommend actually putting the outside, and that's my preference, putting the outside layer of the sling over the opposite shoulder, because one end goes over the opposite shoulder, one end goes over the affected side shoulder. So fold the patient's arm across their chest. The patient can't hold his arm, have somebody else do it. Apply one corner up over one shoulder, you pick. Take the other end of the from the long end near the on the wrist end of it, and go up over the other shoulder. Drop the ends of the sling so the patient's hand is about 4 inches above the elbow, preferably a little elevated like they're showing it here. Tie the two ends of the sling together. Make sure that the knot doesn't press against the back of the patient's neck, so they put a bulky dressing underneath it there. You can pin it if you want. Do not tie around the neck. Check the distal pulse, CSM, with those exposed fingertips. And you can pin or tie a knot in the backside there. If you've learned the pigtail knot on the backside there, that works just fine as well. And they're going to do the pigtail knot. And then form the swath, a couple inches wide, goes around the arm, and then ties off. It should be tied. Do not place it over the patient's arm on the uninjured side. I generally recommend, though, that you tie it under the patient's arm on the uninjured side. Recheck CSM. The long backboard. In addition to immobilizing the spine, we can use it to immobilize their entire body. So in the cases in which we really need to get scooting down the road, we use that long backboard to get the patient log rolled onto the long backboard and get them immobilized and moving. Moving a patient, it helps us move the patient without complicating any extremity injury that he may have. So as long as we're doing a good job of mobilizing, padding voids, using straps, whatnot, we should reduce the probability of additional injury. And we have the traction splint. This one is referred to as the bipolar traction splint. Most of you would call this the hair traction splint. Hair is actually a brand name, so this is a bipolar traction splint because of the fact that it has two poles. The other option is the unipolar traction splint, which is the Sager. I don't know that we even have a picture of a Sager until later. Well, we have one later in the PowerPoint here. So, but you can see several parts of the bipolar traction splint here. So there is one and only one fracture or fracture bone that we can use a traction splint on, and that is a femur fracture. It needs to be a mid to upper shaft femur fracture, and it really kind of has to be isolated. We can't have a hip injury involved. We can't have lower leg injuries involved, otherwise the traction splint will mess that all up. So the traction splint helps to overcome the spasms of that thigh muscle that accompany any femur fractures, because that's the longest and strongest and heaviest bone in the body, and it is surrounded by the thickest muscle mass in the body. So when it fractures, those muscles are going to start pulling. And when they start pulling, they're going to start actually shredding more muscle tissue because the bone ends the bone is getting shortened, and the bone ends are slicing then through the meat. So when this traction splint pulls that thigh muscles out to a normal length, it allows those bone ends to kind of get back into basically a semi-normal position. It's going to decrease the volume of space available to collect blood, and it's going to align those ends of the femur, hopefully reducing pain, keeps them from slicing more stuff up. And then it helps use the thigh muscles to help provide extra stability. It works off of the principle that that frame has to fix at some point on the skeleton, and that's either at the ischial tuberosity, which is the kind of little butt bone, up underneath, say, the pockets of your pants on the backside, and the frame attaches to a second point to apply traction, and that's usually down at the ankle. Unipolar versus bipolar. Bipolar, commonly what we call the hare. Unipolar, commonly what we call the sager. Here we have an improvised splint. They've decided to use a beach towel here. Sometimes we use things such as pillows. We might use a magazine. So there's all kinds of things that we can occasionally get. I mean, in a pinch, we use things like a stick. So there are other things that can get used. I mean, whether we need to cut up a piece of cardboard, or maybe we find a piece of, trim wood laying around that has no nails in it. We have all kinds of things we can improvise to create a splint. Basically, we're just trying to restrict movement and motion. So you can be creative as long as we adhere to those general principles of splinting. So distal swelling is a major component of all fractures, and you will be in the best position to remove items before swelling makes removal without destruction impossible. So what do you have on that might be a problem in the event of a fracture? The most common problem that people end up having with swelling distal to a fracture or an injury is rings. Rings are generally intended to be fairly tight on your fingers, and they don't easily come off, like many bracelets or watches, those sorts of things. Rings tend to be much tighter on there. We don't want them to slip off, and so that has to be a potential consideration. So we respond to a patient, and we're dealing with a fracture, say particularly, of the upper or of the lower arms, or the forearms, or even potentially the lower legs, because toe rings are certainly an option. We may be in the best spot there to say, let's remove your rings before things start to swell up. Just be careful, be cautious, hand them back to the patient, ask the patient, what do you want me to do with them? Maybe there's a spouse or a loved one there that can take charge of them. So fractures are breaks in the bone. They can be things that are small. They can be hairline cracks. They can be severely fragmented. They can be very big, obvious breaks in the bone. They'll result in from a variety of forces, either direct, so say you get smacked with the ball bat, indirect. I think our best example of that would be, say, a fall from a height. You land on your feet, and that shock wave kind of goes up through your legs, and it starts to break some of your vertebrae, or even a twisting motion. Occasionally, we'll see this, say, with people who wear spikes or cleats in sports, where their foot is kind of planted, their spike or their cleats kind of got them planted in the ground there, and then they go to take off quickly and try to push away, yet their foot doesn't spin and swivel like it should, and that twisting force alone can be enough to fracture things. So some types of forces, I think we've kind of talked about this. So stepping into a hole while running, so you twist your ankle. That would be an example of twisting, indirect, falling on an outstretched hand, and it kind of sends a little shock wave up to your radius and ulna, because you don't fall on your radius and ulna, you fall on your hands. We can have them from a variety of mechanisms, typical of assaults, falls, gunshot, motor vehicle crashes, other substantial forces, occasionally from things such as explosions. Occasionally, they're also caused by, well, they got gunshots in there, I was going to say, caused by projectiles or penetrating trauma. Pathogenic fractures or pathologic fractures. These are bone breaks because of a disease. So say somebody with osteoporosis, there's some other things that will cause Paget's disease, causes some odd growth of bone tissue. So where people have very brittle bones and they break apart when for really what appears to be no reason. So they may have a bone cancer of some sort, and even just standing up or stretching out their arm can be enough to break it. So several different types of fractures we can see in the picture here. This picture also is in your text on 828. You see the first bone, the first fracture there is called comminuted. A comminuted fracture is basically a crushed bone. We've broken it into significant little chunks, parts and pieces. Impacted, where the bone actually got compressed on the ends, and it actually has started to crush it from kind of the middle out. Green stick is an incomplete one, basically like pulling a stick off of a still living tree and trying to just snap it in half. It doesn't quite do that. Very common in kids who haven't fully calcified. An oblique fracture is one that's diagonal across the bone. We have a spiral fracture, in which it's just as it sounds, it spirals, usually caused by a twisting force. It looks similar to an oblique, but it usually is splinted or fractured in a spiral staircase appearance. And then we also have transverse fractures that are the nice, clean, easy ones that break straight across. There's 06 again. Open versus closed. Formerly, we referred to open fractures as compound. They're no longer classified as compound. The terminology has just been simplified. So we have open versus closed, where we used to have compound versus simple. And very descriptive now. So open fractures are those in which the bone has protruded out. So some other complications of fractures. First of all, laceration of blood vessels and nerves. We've talked about that previously, where people have that neurovascular bundle that usually runs right along the shaft of a bone. And when you have that neurovascular bundle so close, a small fracture and just a little bit of displacement of that fracture can lacerate those things. Bleeding can be substantial, can become life-threatening, particularly femurs and pelvises. You can lose liters of blood into those areas. So when we're talking, if we broke two femurs, both femurs and our pelvis, it's possible for us to bleed out our entire blood volume right there in 3 fractures. Well, it's probably actually going to end up being 4, because almost always, this is basically almost a guarantee that if you fracture your pelvis in one spot, you fracture it in a second spot, because it's a ring. So those fractures particularly have life-threatening implications. Of course, when we have broken bone ends, we may end up with permanent disability or dysfunction in that extremity as well. So you may never walk quite right on it again. You may never have sensation correct again. It may be permanently weakened because there was an impingement of some sort. So the 5 P's of compartment syndrome, you'll find we've talked about these in the past, but you'll find them on 829. It's pain, paresthesia, pallor, paralysis, and pulselessness. So pain, pretty self-explanatory. Paresthesia, that's that pins and needles tingling sensation. Pallor is the pale coloration. Paralysis is loss of use, or weakness actually can be used there as well. And pulselessness, so they lose pulse. That's rather generally a late sign, but once they lose the pulse, they're definitely becoming quite ischemic. So to manage long bone fractures, we have a large variety of things that are at our hand to use for most patients. Femur fractures, the preferred method of splinting femur fractures is going to be traction splints, simply because of how much we have to combat, how much we have to fight against when we're talking severe, huge muscle mass. There's a video on long bone fractures. Alright, so if we're dealing with long bone fractures, first control any bleeding. Place the dressings on any open wounds. Cover up the wound. Keep out as much dirty stuff as possible. If we can prevent or reduce the likelihood of an osteomyelitis, great. So keep it as clean as possible. Do not attempt to replace broken bone ends or fragments back into the wound. Occasionally in the process of splinting, they will actually go back in on their own. We did not intentionally do that, but occasionally that does occur. So apply manual stabilization. I want to draw your attention to that term directly. I'm going to highlight it even here for you. Manual stabilization. Okay. And the reason I do that is occasionally we get people who are talking, oh, I'm going to apply manual traction. Well, in reality, the traction means to pull. And you don't want to be pulling on any of these things. Even in a femur fracture, you want to provide manual stabilization, because to try to apply traction without having good purchase points is just a futile effort. Not to mention, it's going to be very difficult for you to provide significant amount of pull against all those muscles in the thigh anyway. So stabilization. I've heard people say, I'm going to provide C-spine traction. No, you're not, because if you provide C-spine traction, there's a possibility you're going to kill them. So stabilization. I know it's kind of an anally retentive thing, but nonetheless, it's important. So distal stabilization of the suspected injury. Assess the CSM. So here he's checking for a sensation. If there's a deformity that's severe, if the pulses are absent or the distal pulse is cyanotic, align it into a gentle neutral position using manual traction and stabilization. Yes, it's going to hurt. The reason we're going to do this, if it's got severe deformity, missing pulses, cyanotic, is we need to restore appropriate blood flow back into that extremity. Yes, it's not going to be fun for them. So maybe this is something we hand them the regulator to the nitrous oxide and have them go to town with it. Measure the splint for appropriate proper length, because usually our splints come in a variety of sizes. So we need to make sure we get the appropriate size splint. Secure it however which way we're going to do it. In this case, they've chosen to use the vacuum splint. So we're going to immobilize into the position of function. Remember, mobilizing the position of function in the hand means place something cylindrical, usually in their hand, for them to hold on to and wrap their fingers around. Puts it into the most relaxed position for that to be in. With the foot, the position of function is generally with the foot basically at around a 90-degree angle, if not slightly extended. After you've completed the splinting, reassess the distal neurovascular function, so recheck CSM. Depending on the type of splint you use, you may have to do some readjustments. You may have to do some additional little details. Say, for example, this vacuum splint here, almost always after you have sucked all the air out, you then have to go back and retighten those straps so it does so it's secure. Managing long bone fractures after immobilizing the extremity with that splint. If we can elevate it, please elevate it and consider applying a cold pack. Reassess them frequently on the way to the hospital. Should we have things start to pop up like the potential for a compartment syndrome, humeruses and forearms, splint generally with a rigid, moldable, pneumatic vacuum splint, and use a sling or swath to help support and immobilize the arm, the elbow, and the shoulder. If we're talking femurs, generally the traction splint, unless we have other contraindications. If we have other contraindications, then we would use a rigid splint. Be generous with your padding. Yep. Lower legs, again, we got a large variety we can pick from. Rigid, moldable, pneumatic, vacuum. Ensure that the foot's in a neutral position. We're talking things that are like a foot or an ankle. We can use things like a pillow that's kind of taco shelled up around their foot. The mass pants or the PASG. Those of us that have been around the EMS world for a while are familiar with PASG. It was something that we spent a significant amount of time learning in many of our classes. The PASG, in theory, were used to treat people with shock by quote-unquote auto-transfusing blood into their core. They are currently not recommended for that, but they do a great job of immobilizing massive lower body trauma. So you could splint both legs and the pelvis with a PASG. We also have some pelvic binders. This one's called the T-pod device. These are intended, particularly the T-pod here, is intended to help kind of close what they call the open book fracture. So because I've said that when you break a pelvis, you usually break it in two spots, that makes a very unstable environment because two spots on the ring will break, making that pelvis very unstable. So this is why when we push, when we're going to assess a pelvis, we just very lightly put pressure on the pelvis downward and very lightly put pressure on the pelvis inward. It doesn't take much because we will know immediately whether or not it's stable, and the patient will let us know whether or not that really hurts. So not to mention, if we just get too into it, we're just going to blow clots, and that's going to end up causing major problems for the patient in the future and can cause some more severe bleeding. So this T-pod device, basically it has it's harder to see here, but kind of going between those orange buttons is some monofilament line, basically looks like fishing line, that they all cinch together at the same time, and it's a Velcro winch system that kind of allows you to tighten this thing up around there. I'll be honest with you, the research doesn't necessarily support the use of this in the field. They came out great guns that they were running around telling everybody that these are the best things since sliced bread to help take care of a pelvic fracture. And the research was done by orthopedists in a hospital. It was never done in the field, and there's not a lot of studies that actually lend to credibility for use in field use. Additionally, we can look at things such as a KED. If you apply a KED, sometimes backwards, or not backwards, but upside down, around a pelvis, it does a great job. Some people will tie bed sheets. So there's several different types of things you can use to potentially immobilize a pelvis. Even a backboard with appropriate padding does a good job. Scapula and first rib injuries, that force required to break those is so significant it can cause a lot of damage to the interthoracic organs. So if you suspect a fracture that high, we'd want to be particularly concerned with what may also be going on internally. Broken clavicles, those can lead to pneumothorax or even a hemothorax. Pelvic fracture, as I mentioned, can be an open book where it increases the volume of the pelvis and can cause up to 2 liters of blood loss. So use your local protocols for immobilizing the pelvis. Femur fractures, you can lose up to 1,500 mils of blood per femur. So bilateral femur fractures, you can lose up to 50% of your blood volume. All right, here we again have the bipolar traction splint, or the hair, and here's the unipolar or Sager. The nice thing about this model of unipolar is this is actually a bilateral splint. You can splint both femurs at the same time with one splint, whereas if we look here at our bipolar traction splint, you need to have one for each leg if you're going to splint 2 femur fractures. So, do not apply traction splint for the following situations. Injuries within 2 inches of the knee or the hip. If you have a hip or pelvis injury, chances are you're going to be pushing on stuff you don't want to be pushing on, and it's going to cause some potentially very negative side effects. And then any injury lower than the knee. So basically, if it's 2 inches above the knee or lower, you should not use a fracture. A traction splint, sorry. Should not use a traction splint for the simple fact that if you don't have a stable and intact bone to pull on there in your tib and fib, you run the risk of I guess in theory, ripping their foot off. So obviously not something that we're hoping happens, but it certainly could. And we have to have something that we can actually, that's steady, that we can pull on. So to apply the unipolar traction splint, assess the neurovascular function, place the splint along the medial aspect of the injured leg, adjust it so that it extends about 4 inches beyond the heel. This is preliminarily. Secure the thigh strap. Apply the ankle hitch and attach it to the splint. Apply traction by extending the splint and adjust the splint to 10% of the patient's body weight. So there's a set of numbers on, really it's basically between his hands there. It's kind of hard to see. So if you take and drop off the last number of your kilograms, you end up with 10% of their body weight. And so that's what you're going to adjust it to. Generally, you're going to start to also see on the wheel here, and actually that's what I was shooting for. Sorry, it's not between his hands here, it's what's on the wheel. As you pull on it, the wheel, get this highlighter out again, right in here, as that wheel pulls around, you're going to start to see the numbers progressively get larger as more and more traction is put on. That's what you're going to end up watching for when it comes to their appropriate amount of traction. I think probably a better indicator, though, is when the patient starts to gain a little bit of relief. And then finally, you're going to apply the leg straps to secure the leg to the splint. We're going to apply the top strap is over the suspected site of the fracture, the middle strap is over the knee, and the bottom strap is mid lower leg. secure them to a long spine board. Remember, if they suffered an injury that had enough force to break their femur, probably a pretty good chance they're also going to need spinal mobilization. Now to do the bipolar. So check CSM. They didn't recheck CSM after the unipolar splint, but of course it's check and recheck. So assess distal CSM. Stabilize the injured leg, and I hate that they say apply manual traction, but appropriately it's just apply some stabilization. Keep it from bumping around. You don't have the strength to compete with their thigh. And I think it's better to point out that you need to be higher up on that patient's thigh. You need to get a hand under the suspected fracture site to give some stabilization there. Otherwise, it's just sagging. Adjust the splint for the proper length using the uninjured leg as a guide. Usually we'll go about 10 to 12 inches longer than the uninjured leg. Position the splint under the patient's injured leg until the ischial pad rests against that bony prominence of the buttocks. And when the splint is in position, then you raise the heel stand, the kickstand. Attach that ischial strap over the groin and the thigh. And I like to actually go kind of, if I can get it diagonal up, kind of up along their crease of their leg there, their pelvis and leg crease. I try to. It gives you a little bit better purchase. It holds it a little harder, a little bit more steady when it's up high. So make sure that the ischial strap is snug but not tight enough to reduce distal circulation. You really honestly would have to be ridiculously over the top, super strong man in order to get that to happen. With the patient's foot in an upright position, secure the ankle hitch. Attach the S-hook into the D-ring and start to apply the mechanical traction by rotating the little traction dial there. You're going to continue to apply that traction until the muscle spasms are reduced or until it's at least the same length as the uninjured leg. Then you'll go back and fasten the leg support straps, and the top strap should be above the suspected fracture site if possible. The second strap should be below the suspected fracture site but above the knee. The third strap below the knee, and the fourth strap just above the ankle hitch. Recheck the CSM. Reevaluate the ischial strap to make sure it is also secure. Mobilize the patient onto a backboard. In many cases with the hair or the bipolar splint, that can be a trick because this is going to now make a fairly long contraption. We may have to get a little bit creative in how we secure this to the backboard and to the cot. We may have to have the patient actually up a little farther up on the cot. So, and then pad between the legs. So padding, securing to the board, securing to the cot, all reduces that potential for movement. I mentioned that we can have pretty severe blood loss from a femur fracture. The average adult has 4 to 5, in some cases 6,000 milliliters of blood. And so how does that application of that traction splint control that bleeding? It reduces that potential cavity in there, and it puts the things back into alignment, and it puts a little extra tension on those muscles so they can't let as much bleeding occur. Here we have a knee dislocation, and I'm guessing that one hurts. We have a picture of it here. Oops. There's an x-ray of it coming up. But the sprain is a joint forced beyond the normal range of motion, stretching or tearing of ligaments around the joint. We can have an avulsion fracture, where a ligament actually starts to tear away a piece of bone as it gets stretched and torn. We have dislocation, which is a displacement of a joint, usually produces a pretty obvious deformity, and sometimes, well, a lot of times, a decrease in use. Subluxation is a partial displacement of a joint, so kind of people call it a trick knee, but it's a subluxation. Okay, so here's that picture of that dislocated knee on the outside, and there's the x-ray. So that sucker is way out of whack. You can see the patella way up and out of the way there. So we have a pretty incredible little knee dislocation there. Hip fractures and dislocations. These usually involve the proximal femur as well. Sometimes the hip fracture is the neck of the femur. Some people believe it's a pelvic fracture, but in most cases it's not. Once in a while you actually do pop through the acetabulum. So you break the acetabulum, which is the cup that head of the femur sits in. With dislocations, that head of the femur gets displaced either to the front or to the back of the pelvis. So it just sits outside the cup, either forward or backwards. Often will occur from falls or forcing a joint beyond the normal range of motion. So somebody who has maybe been in a car accident, sometimes it gets popped out. This will be very painful, and they recommend using scoop stretchers whenever possible here. It tends to reduce the amount of rolling and uncomfortable movements. So they have a hip fracture animation for you to watch in the other one. Elderly patients are obviously at a much higher risk for hip fractures and dislocations. Being that femur is so large and that muscle mass is so large, you run that high risk of them slipping, falling. They've lost their balance, not to mention they've probably lost some bone mass. They also may have a higher pain tolerance because their perception of pain tends to decrease over time. And then some elderly patients will even walk around on a newly fractured hip and not know it. Sometimes it's an impacted fracture in which it actually kind of crushed everything in on top of each other, and it was still functional, but not optimal. Strains are when muscle fibers get stretched beyond their limitations, and it may also result in some tearing of fibers. And the muscles are under extreme stress, say from lifting, typically would be strained. So think about it. Has things changed since the beginning of the chapter? Whoops. Musculoskeletal injuries consist of groups of injuries involving bones and joints. Some of the injuries may be obvious and gruesome, some less obvious. Don't allow these gross, obvious, or these distracting injuries to distract your attention from the life threats. When life-threatening injuries are not present, we'll assess and manage those musculoskeletal injuries by splinting. We have tons of different splints to choose from. Be familiar with the use of all of them. Purpose of splinting reduces pain and additional injury. Remember the above and below rules for splinting. It's either the joint above and below a bone or the bones above and below the joint that's injured. A splint the injury appropriately. If you don't, you can lead to further injury from something like a compartment syndrome. Assess your distal CSM before you splint and after you splint, and document appropriately.